A diagnosis of hyperimmunoglobulinemia recurrent infection syndrome was made based on a history of recurrent Staphylococcus aureus infections, extremely elevated serum IgE, and positive anti-Staphylococcus aureus IgE antibodies. Over the next 2 years, the patient was seen in hospital with recurrent cold staphylococcal abscesses, otitis media, and adenitis and was prescribed daily prophylactic flucloxacillin, and at 2 years of age, he developed a right lower lobe pneumonia and the causal organism was again identified as Staphylococcus aureus. Despite the use of parenteral flucloxacillin, a right-sided pneumococcal developed that was later complicated by a pneumothorax. Hyperimmunoglobulin E syndrome with recurrent infection is an uncommon idiopathic primary immunodeficiency. Symptoms of hyper-IgE syndrome usually begin during infancy. Patients with any kind of excessive IgE syndrome frequently struggle to control pathogenic infections, and they are also at a significant risk of breaking bones, having a bent spine, and having facial and dental developmental issues. The clinical manifestations include recurrent skin and lung infections, elevated serum IgE, changes in connective tissue formation and repair, vascular abnormalities, and tumor growth. Deep tissue abscesses are commonly encountered, most frequently caused by staphylococcal infections, and the majority of HIES cases are sporadic. However, certain familial instances can be passed down through either an autosomal dominant or autosomal recessive gene. The diagnosis of HIES can be made based on a combination of clinical and laboratory findings. The treatment involves giving antibiotics to prevent or treat infections, creams or medicines to relieve the rash, and medicines that modify the immune system. HIES has a clinical phenotype that includes both excessive and insufficient inflammation. Pneumatocells, which are caused by persistent localized inflammation in the lung, are an example of excessive inflammation, whereas opportunistic infections and the typical cold boils are instances of insufficient inflammation. The aim of this study is to learn more about the illness in order to comprehend its precise pathophysiology, clinical manifestations, and therapeutic options for individuals with hyperimmunoglobulinemia recurrent infection syndrome.
Patient's characteristics, the signs and symptoms. Peter, the patient in this case study, was delivered at term and weighed 4.1 kilogram after a routine pregnancy. He acquired a vesicular rash on his body and face when he was in the newborn unit. 10 days after being released, he was readmitted at the age of 8 weeks due to a fever, a broad vesicular, whipping, encrusted skin rash, and poor feeding. He was found to be febrile and to have otitis externa, which was identified by the purulent discharge coming from his left external auditory meatus. He also acquired oral candidiasis while he was in the hospital. When Peter was 10 months old, his left axilla had a painful lump that was later determined to be axillary adenitis. His weight and height were on the third centile at the time of his appointment, and a degree of developmental delay was detected. He was unable to stand and had not yet begun to talk. Over the course of the following 2 years, Peter underwent hospitalization for recurrent otitis media, adenitis, called staphylococcal abscesses. At his age of 2, he experienced pneumonia in his right lower lobe. There was a delay in verbal, general motor, and fine motor abilities during this visit.
Peter's laboratory test showed congruent results in regards to his condition. His white cell count was 25.1, which is abnormally high from its normal values of 6.4 to 11, and neutrophils of 18.3 from its normal values of 2 to 7.5. He was positive for S. aureus, and this triggered his innate immune system to produce more leukocytes in response to microbes detected. Inflammation from his axilla was due to the infection that caused his lymph nodes to swell. It was evident after the flocculent mass was surgically drained. Peter's IgE levels were extremely elevated due to recurrent S. aureus infection. This was evident from his test showing an IgE level of 245 from its normal values of 3 to 22 IgE IU per ml. He was later diagnosed with hyperimmunoglobulinemia E recurrent infection syndrome after 2 years of continual colds, staphylococcal abscesses, otitis media, and adenitis. The results from his prick test also showed positive results after common allergens were performed. This was apparently due to his extremely elevated IgE serum levels. IgE is responsible for the hypersensitivity reaction as it binds to the Fc-bearing cells like eosinophils, basophils, and mast cells. Mast cells are derived from precursors in bone marrow that migrate to specific tissue sites to mature and are principal effector cells of immediate hypersensitivity. They contain numerous cytoplasmic granules which include histamine, while basophils possess histamine-rich granules and high-affinity receptors for IgE. Peter's case of hyperimmunoglobulinemia E recurrent infection syndrome is a subject of complement deficiency. C2 deficiency is the most commonly occurring deficiency. Individuals who lack C2 are prone to developing recurrent streptococcal, staphylococcal infections, and atherosclerosis. It is a genetic condition that affects the immune system. Signs and symptoms include recurrent bacterial infections and an increased risk of a variety of autoimmune conditions. It can be confirmed through laboratory evaluation of complement pathways and components. Two techniques to determine complement abnormalities are immunologic assays of individual components such as radial immunodiffusion and defillometry, and overall complement activity measurements such as CH50 and AH50 tests.
Each IES is defined by elevated serum IgE, eosinophilia, reduced C3b receptors on neutrophils, decreased adhesion molecule L-selectin, decreased IFN synthesis or secretion, absence of transforming growth factor, and aberrant neutrophil chemotaxis. In each IES, patients impaired with IL-12/IL-18/IFN axis leads to failure synergistic activation of T cells. Ito et al. Proposed that defective intracellular secretion pathway might be one of the causes. Recombinant IFN gamma has been linked to autoimmune thrombocytopenia as a side effect. The hyper-IgE condition is induced by TGF and IFN dysregulation in activated T cells. These genes are essential for the pathogenesis of HIES, immunological components. They may also be responsible for the poor neutrophil chemotaxis found in this illness. High IL-10 concentrations contribute to the atopic nature of this condition, which includes high IgE levels, eosinophilia, allergic responses, and persistent dermatitis. IL-13 suppresses osteoblast formation while stimulating them to create IL-6, a potentiating osteoblast factor. Because of the diverse phenotype of each IES, it is possible that it is caused by mutations in various genes in different families, or by the deletion of contiguous genes in a short chromosomal area. Renner et al. Examined 13 individuals who were seronegative for the human immunodeficiency virus. A STAT3 gene mutation causes low bone density and frequent fracture. Th17 cytokine is essential in the defense of the mucocutaneous candidiasis. Filaggrin helps to reduce water loss, leakage, and the entry of infectious germs into the epidermis. The most prominent immunologic aspects in HIES patients consist of defective granulocyte chemotaxis when activated by endotoxin and or formyl methionine lysyl phenylalanine phagocytic cell ingestion, metabolism, and bacterial killing are all normal. IgE production may be elevated due to an increased number of B cells making subnormal levels of IgE. Eosinophilia in the blood, sputum, and abscesses is seen virtually in all patients. Flow cytometry analysis revealed abnormal T lymphocyte subsets. In some HIES patients, raised levels of urinary histamine were correlated with eczematoid dermatitis. The diagnosis of hyper-IgA syndrome is hypothesized based on symptoms and verified by blood IgA level testing. Genetic testing can discover gene mutations and is used to validate diagnosis or forecast inheritance patterns, and genetic tests can be done to check for the abnormal genes.
The hyperimmunoglobulin E recurrent infection syndrome is characterized by recurrent bacterial infections of the skin and sinopulmonary tract that starts in early childhood or infancy and occur when there are at least 10 times the usual levels of IgE in the blood. Core species persistent eczematoid rashes, cold cutaneous abscesses, moderate eosinophilia, mucocutaneous candidiasis, and the neutrophil chemotactic deficiency are all potential complications of HIE. Staphylococcus aureus and Haemophilus influenzae are the bacteria that typically infect these people. However, Streptococcus pneumoniae and enteric gram-negative rods are occasionally seen. Deep-seated infections, aside from pneumonias, are uncommon. However, osteomyelitis, arthritis, and visceral abscesses are common. Sepsis and bacteremia are uncommon, and long-term intravenous antibiotic therapy and early surgery are necessary for the treatment of infections that typically appear to be benign.
Pathogenesis of this disorder. The pathogenesis of this disorder is influenced by immune system dysregulations, even if the precise immunologic abnormalities and underlying causes of HIES are not fully known. Important contributions are the following characteristics of HIES: elevated serum IgE, eosinophilia, elevated GM-CSF, decreased C3b receptors on neutrophils, decreased adhesion molecule L-selectin, decreased IFN production or secretion, absence of transforming growth factor or the TGF, suboptimal response to interleukin 12, IL-12 stimulation, and abnormal neutrophil chemotaxis. However, the condition is strongly hypothesized to be brought on by abnormal neutrophil chemotaxis brought on by T cells producing decreased interferon gamma. There are two types of inheritance described: the autosomal dominant and recessive. Autosomal dominant. STAT3 may show as HIES with recognizable skeletal, dental, and facial deformities that have been dubbed as Jobs syndrome. Fated, which stands for course of leonine faces, cold stap abscesses, retained primary teeth, elevated IgE, and dermatological issues, or eczema, as a popular acronym for the symptoms. After cytokine profile suggested changes in the STAT3 pathway, the condition was connected to mutation in the STAT3 gene. This change pathway directly lowers the ability of the interleukin 6 and 10 to modulate immune responses, which in turn inhibits the development of Th17 cells, which collaborates also with CD4 cells to protect against bacterial and fungal infections and promote the misguided immune responses seen in people with Jobs syndrome. The genetic condition hyperimmunoglobulin E syndrome, which is characterized by increased immunoglobulin E levels, eosinophilia, and recurrent infections with staphylococcus and viruses, has an autosomal recessive variant called the DAC8 immunodeficiency syndrome or DIDS. It is brought on by a DAC8 gene mutation, which predominantly manifests as immunological reactions like HIEIS. Eczema is prevalent. Food and environmental allergies are frequent, and anaphylaxis and asthma have also been observed on this occasion.
Atopic dermatitis, allergic fungal sinusitis, allergic bronchopulmonary aspergillosis, human immunodeficiency virus infection, hyper IgE syndrome, IgE myeloma, lymphoma, and systemic parasitosis are among the diseases linked to exceptionally high serum IgE concentrations. IgE levels were greater in those with cardiovascular illnesses, particularly in those who had unstable angina and acute coronary events, according to several epidemiological research. However, it is yet unknown if the elevated IgE level is a predictor of upcoming coronary events and whether it may be considered as a risk factor for ischemic heart disease. IgE has a significant role in the etiology of atherosclerosis, according to a new molecular study that shed further light on the connection between high IgE levels and atherosclerosis. Clinical evidence is still required, nevertheless, to show that having high IgE levels raises the possibility of developing atherosclerotic outcomes. Very low or absent IgE levels were more susceptible to tumor growth. Generally, allergists diagnose patients with IgE deficiency during the workup for elevating persistent respiratory symptoms that resembles allergies. Compared to IgE deficient individuals with evidence of mast cell bound IgE, those IgE deficient patients with absent cell bound IgE or negative type 1 hypersensitivity skin test had the highest likelihood of receiving a diagnosis of an associated malignancy. IgE deficient people have a higher risk of developing cancer.